1, start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. So today we have a presentation on functional disorders of lower unit tract dysfunction in children, and will be presented by our resident Dr. Abhishek Jain and would be moderated by our faculty Dr. JANGID. So I would request Dr. Abhishek to kindly share his presentation. This one?
Thank you, sir. Good morning, everyone. Today's seminar is on functional disorder of lower urinary tract in children. So these are the abnormalities in the filling and or the emptying phases of the bladder, and they originate from the behavioral factors that affect toilet training and inhibit the development of normal urinary control. Epidemiology, up to 40% of pediatric urology clinical visits annually are due to lower urinary tract dysfunction. The most common urinary symptoms include holding maneuvers and urgency, and the constipation is most common comorbidity. The diurnal incontinence is present in up to 30% of the children's, and it is common in children with comorbid behavioral issues, and they may have negative impact on the outcome also. So clinical evaluation, first we take history. Apart from routine history, we try to identify an anatomic or neurological etiology. We ask for voiding frequency, bowel function, developmental milestone, especially the toilet training, neuropsychiatric conditions, social history and diet, and incontinence, whether it is continuous or intermittent, day versus night, and how often. We ask for history of UTIs, neurological functions, both upper and lower extremities. And there are some questionnaires to accept the symptoms like DVSS, DVISS, ISIP, to assess the quality of life like PIN-Q index, and for behavioral changes, CBCL and SSI-PP. There is bladder and bowel dysfunction due to similar innervation through the sacral nerves. And we should ask for abdominal pain, size of stool, and consistency, and according to the Bristol stool scale. Then we have some clinical aids, the 1 week or 7 days voiding and bowel diary. And this we mark if the bladder is emptied by X, and if there is dampening means small leakage marked by S, and the large leakage, that is soakage, is marked by L. And the stools are marked according to consistency by Bristol stool scale, which is provided separately. And at night we mark whether the child remained dry or wet. Then we can go for 48-hour voiding diary. This will help the doctor to identify how well the child empties his or her bladder, and it is best done on a quiet weekend. This is the Bristol stool chart. There are 7 types. The type 4 is the ideal smooth shape and easy to pass. Coming on to the examination, we look for vital signs, and if there is abnormal BP reading, we can go for appropriate investigations like renal sonography, urinalysis, serum creatinine, or cystatin C. We measure the BMI because abnormal BMI, low or high, can lead to lower urinary tract dysfunction. Then there is triponderal index, which is mass upon height in meter square. This is the ideal posture for sitting on the toilet. We can provide support to the feet if necessary. And the child should avoid dangling over the edge. It will increase the pelvic floor muscle tone. And we can ask them to sit backward facing the trunk so that the legs are not crossed. Then there are some holding maneuvers, which is also known as doing the potty dance, which includes posturing, grabbing the perineum, crossing the legs, and squatting. This will increase the perineal pressure and inhibit bladder contractions, likely through the increased efferent co-signaling. The neurological examination, inocutaneous reflex, by stroking the anus, the external anal sphincter is contracted. The bulbocavernous reflex, on squeezing the penis or pulling the follies, the anal sphincter is contracted. The absence indicates that there is interruption of the sacral reflexes and bowel and bladder dysfunction. Then we should look for the spine. For the neural tube defects, the skin changes may range from dimple less than 2.5 centimeter from the anus, the macules, deviated gluteal cleft, a mass, or a tuft of hair, which is considered high risk. We should examine the genitalia for dampness or any signs of irritation, and in females, the introitus for signs of pooling of urine or ongoing inflammation. We would look for ectopic ureteric orifice and labial fusion. It is seen in less than 2-year girls who are still in diaper, but it rarely causes bladder outlet obstruction. Treatment is usually conservative, but we can also give topical estrogen creams, but 10% cases can still recur. Then lab testing, the simple non-invasive test is urinalysis. A negative urinalysis is always reassuring, and microscopic hematuria may be present, but it rarely requires workup if the patient is asymptomatic. Then we can go for urine culture if there is high probability of UTI. Malodorous urine alone is not sensitive or specific to rule in or rule out testing. And if it is isolated, we should just increase the hydration. It will dilute the volatile compounds and change the specific gravity. Then urodynamic evaluation, the uroflowmetry, which measures volume per time. It can be used concomitantly with EMG. The most relevant parameter is Qmax, but the peaks may be artifactual. So it should be registered only when it lasts for more than 2 seconds. These are the normal curves. First one is the bell-shaped curve. Second one is the obstructive flow pattern. Third is the flow starting and stopping, also known as staccato pattern. And fourth one is peak flow pattern with the rapid emptying. This will cause turbulence and symptoms. Then some caveats. To obtain an interruptible flow, the child must be toilet trained, and uroflowmetry only provides the information during the elimination phase, not the storage phase. When the voided volume is less than 50% of the expected capacity, the results are usually not valid, and it is important to obtain more than one curve. Then pelvic ultrasound, it is a useful tool to determine if further imaging testing will be helpful. And we measure the bladder thickness. If more than 5 mm thick when empty and more than 3 mm when full, it is called thickened bladder. It will indicate detrusor workload overactivity and increased activity of pelvic floor musculature. This is the ultrasonography showing thickened bladder. And these are the stools which are distorting the shape of the bladder. And these are the debris. Then bladder volume wall index, it is the ratio of bladder volume to the wall thickness, normally 70 to 130. It is highly predictive of the normal bladder function. And if there is nocturnal enuresis and normal index, there is better response to desmopressin therapy. Abnormal is if it is more than 130, that means the bladder is thin and high capacity. If it is less than 70, it means the bladder is thick and small capacity. Then we can use patch electromyography, which tells about the coordination between pelvic floor musculature, sphincter relaxation, and the bladder emptying. It is non-invasive test and provides electric potential of the musculature, which should normally be quiescent during voiding. Uh, this is the normal physiological activity of the bladder and external sphincter. On giving the command to void, the external sphincter relaxes and the patient micturates. The lag time is the time from the start of the relaxation to the beginning of the urine flow, which is normally 2 to 6 seconds. If it is less than 2 seconds, it indicates detrusor overactivity. And if it is more than 6 seconds, it indicates primary bladder neck obstruction. To calculate the estimated bladder capacity in infants up to 1 year, it is weight into 7. And in older children, it is age in years into 30. The functional bladder capacity is the day-to-day working capacity of the bladder. It is the largest volume recording on the voiding diary or the voided volume on uroflowmetry plus the PVR. It ranges from 70 to 130%. And the formal UDS is reserved in whom the further testing will change the management. There are some unique considerations in pediatric patients. The risk factors for post-procedure infections are immunosuppression, recently diagnosed UTI, symptoms on the day of procedure, or performing overnight catheterization. Then sedation is not generally recommended as it will alter the results either due to direct pharmaceutical effect or to the neurological pathways. Even if it is required, for example, for placing the catheter, it should be done well in the advance of the study. And for sedation during cystometry, ketamine is considered better than midazolam. The smallest size catheter, typically 6 French double lumen catheter should be used. And if there is vesicostomy, the inflated Foley's can be placed with mild pressure. And if there is catheterizable urinary channel without bladder neck closure, the catheter may be placed either through the channel or through the native urethra. And if there is colostomy, the catheter can be placed to measure abdominal pressure. In females, catheters can be placed into the vagina, and fill rate is 5 to 10% of the expected bladder capacity. The saline or contrast medium should not be too cold. It should be between room temperature and body temperature. Then this is a brief chart. We take medical history and physical examination, and we rule out functional constipation by applying the wrong 4 criteria. We maintain bowel diary for 7 days, and if dysfunction is present, we treat accordingly. If on urinalysis there is any infection, we treat the infection accordingly. On pelvic ultrasound, if PVR is more than 20 ml, then we treat accordingly. And rectal diameter more than 30 mm without an urge to defecate is considered functional constipation. Then bladder wall thickness, if it is more than 6 mm when empty and more than 3 mm when full, we treat the LUTs. If both LUTs and functional constipation improve, then we continue the treatment for at least 3 to 6 months. If only functional constipation improves but LUTs are persistent, then we go for further testing starting from Euroflow or EMG and treat accordingly on the lines of management. If the LUTs improves but there is persistent functional constipation, we ensure that the child is properly toilet trained, and then we treat with polyethylene glycols, enema, biofeedback training. If there is still no improvement, then we go for extensive evaluation by pediatric gastroenterologist. Then there are some comorbidities associated with functional urinary tract disorders. First is UTI. It is not only an effect, but may also precipitate development of some dysfunction like overactive bladder. Association is often noted in conditions in which there is urinary stasis. VUR, detrusor hypertrophy can alter the vesico-ureteric junction, which will lead to reflux. Continued dysfunction is a risk factor for treatment failure or of the reflux. So LUTD must be treated. So the VUR may be treated itself. Then there are psychological association, especially the behavioral issue that originate at the time of toilet training. It is seen that the symptoms are more severe in children who are from the unplanned pregnancy, who attended daycare or have had school problems. In ADHD, there is more severe nocturnal enuresis, and early intervention by pharmacological treatment is more beneficial. Bowel dysfunction, one theory is that the rectal distension will lead to direct pressure on the posterior wall, which will cause detrusor instability and bladder overactivity. The other theory is that both anal sphincter and the urethral sphincter have common input. So chronic contraction of the anal sphincter will lead to secondary detrusor external dyssynergia. Then some conditions of functional lower urinary tract. Giggle incontinence, also known as enuresis dysuria. The urine leakage is triggered alone by laughing. The mechanism is thought to be a cataplexy, that is CNS inactivation in response to the laughter. The episodes are significant. Sometimes the entire bladder is drained. It is a diagnosis of exclusion and can be treated by biofeedback or methylphenidate. Pollakiuria, the extraordinary daytime frequency as high as 50 times. The symptoms are limited only to daytime compared from overactive bladder, and it is seen in early childhood in both gender, associated with the psychological problem like a recent death, and usually benign up to 6 months. Underactive bladder, the child is required to raise abdominal pressure either to initiate, maintain, or complete the voiding. The approach is timed voiding and double voiding, and CIC may be required. The frequency is dependent on the severity. Vaginal reflux, also known as vaginal voiding or entrapment. The incontinence after normal voiding in the absence of LUTs. Typical history will be there will be a prepubertal girl, 10 to 15 years age, who will wet undergarments after passing 10 to 15 minutes after passing the urine, and it may be associated with labial adhesion due to chronic irritation by the caustic urine. Treatment is reassurance and ensure postural modification. Then daytime urinary incontinence and bladder dysfunction. The treatment, the principle is symptom improvement and upper tract protection. The ICS defines treatment principles as assessment of treatment response. It must be based on pre-treatment symptom frequency registration, and the response before and after the therapy both should be calculated because these may not be the same. The treatment can be categorized as initial success, no response if there is less than 50% reduction, partial if 50 to 99% reduction, and complete if 100% reduction is there. The long-term success can be categorized as relapse when more than one symptom recur per month, continued success if there is no relapse in 6 months, and complete if there is no relapse in 2 years. Then urotherapy can be standard or specific intervention. In standard components, we provide information and demystification of the facts and instruction how to resolve the dysfunction like behavior modification. We give the lifestyle advice like avoiding drinks at night and sugar, especially the high sugar drinks. Then registration of symptoms using various charts and mobile applications. And obviously sport and encouragement. Then specific interventions can be biofeedback, neuromodulation, or catheterization. If there is bowel dysfunction, we increase both the fluid and the fiber intake. The fiber intake can be calculated as age plus 15 to 20. And if the fiber intake, with fiber intake, if the fluid intake is not increased, it will lead to small stools binding together and it will increase the constipation. We can titrate polyethylene glycol so that the child is passing Bristol type 4 stools. In severe cases, we use something known as magic mousse. It has three simple ingredients: 1 cup of ice cream, 1 cup of pudding, and 6 ounces of mineral oil. They are mixed and frozen. Less than 6 years of age, we give 60 ml. More than 6 years of age, we give 120 ml. Usually done over a quiet weekend. And the bowel dysfunction treatment is continued throughout the treatment course. It will also counteract the anticholinergic effects of the medications. And it is seen that relief of constipation resulted in disappearance of daytime incontinence in 89% and enuresis in 63% of the patients. Then behavioral modification, timed voiding with the voiding schedule every 2 hours, alarms or the reward system. The biofeedback, it is a non-invasive instrumentation to measure, record, and provide instantaneous information about the voiding dysfunction. It will provide the feedback to the child, and the age must be more than 4 years. The dysfunctional voiding have better improvement than the overactive bladder. Then CIC, it was first introduced by Lepidus in 1972. In the setting of dysfunctional voiding, the bladder becomes chronically overdistending, which can either lead to thickening, which results in overactive bladder, or underactive bladder as a result of myogenic failure. CIC is safe and it reduces the rate of recurrent UTI in the children. Then pharmacotherapy, we can use anticholinergics or alpha blockers. Anticholinergics are the current gold standard. The oxybutynin and tolterodine are used. Oxybutynin is available in various form: oral, intranasal, transdermal. The intranasal and transvesical form avoids the first pass metabolism. The side effects are constipation, dry mouth, altered behavior because of its lipid solubility. The ideal patient for anticholinergic is small capacity bladder and overactive bladder with complete emptying. Alpha blockers causes smooth muscle relaxation, and if EMG time lag time is more than 6 seconds, then we can use alpha blockers. Then botulinum toxin type A, it inhibits the ACH release from the presynaptic junction. The effects begin within 5 to 7 days of the injection, maximum at 4 to 6 weeks, and it will last up to 3 to 12 months. It is directly injected into the detrusor muscle as shown in the picture. It is safe in children and don't induce additional fibrosis in the wall. Then neuromodulation, the electric stimuli are exerted in non-invasive manner to alter the transmission pattern and modulate the detrusor activity. It can be sacral neuromodulation, pudendal nerve modulation, or tibial nerve stimulation. A study shows that up to 10 to 20 sessions may be required, but results are seen in some studies as early as the third session. It is approved by FDA for urinary frequency, urge incontinence, pelvic dysfunction, and non-obstructive urinary retention. Then enuresis, also known as nocturnal enuresis, the discrete episodes of urinary incontinence in children older than 5 years in the absence of any neurological cause. It can be monosymptomatic or non-monosymptomatic. The epidemiology, approximately 15% of the children will have wetting at 5 years of age, and the spontaneous resolution is 15% per year. So at the 15 years of age, only 1 to 2% of the teenagers will still wet the bed. Longer it persists, the less likely is that it will resolve spontaneously. Then monosymptomatic, if the enuresis is without any LUTs and without bladder dysfunction, it can be primary or secondary. In primary, the child has never achieved a period of dryness, and in secondary, there was dry period of at least 6 months. The secondary enuresis can be due to some stressful events like divorce, birth of siblings, sexual abuse, organic cause, or a psychological cause. Then non-monosymptomatic enuresis, if there is any daytime LUTs with enuresis, it can be daytime incontinence, frequency, lower urinary tract pain, holding maneuvers. So we treat the underlying dysfunction first. Coming on to the genetics, if one patient had bedtime wetting, it is seen in 43%. If both parents were affected, it is seen in 77%. Neither parents, 15%. And concordance in monozygotic versus dizygotic is 68 versus 36. The linkage to chromosome 12, 13, and 22 have been reported: autosomal inheritance pattern and high penetrance. The identification of these genes lifts the burden of guilt from the child and dispel the theory that enuresis is completely under their control. Then pathophysiology, three domains are involved: brain, bladder, and the kidney. There is theory of maturational delay in the ultimate development of the bladder control, as most of the children will improve even with or without treatment. Then bladder overactivity and reduced nocturnal activity. If the pelvic floor activity is increased with detrusor contraction, the child will not wet the bed. But if the pelvic floor activity is not increased, child will wet the bed. Then nocturnal polyuria, defined by ICCS as urine production more than 130% of the expected bladder capacity of the age. The normal circadian rhythm of ADH will regulate the free water excretion. Causes of nocturnal polyuria can be increased fluid intake or increased solute load, blunted response to ADH, abnormal sodium, calcium, renal sodium handling, and obstructive sleep apnea or hypoventilation. Not all children with enuresis have nocturnal polyuria, and in those there is polyuria, the ADH may be normal. The osmolality in children with NMSC or without MSC is the same, and it is seen that morning osmolality will increase with the age. It suggests a maturational hypothesis, and arousal and sleep, these patients are described as excessively deep sleepers. There is subjectively high threshold for arousal and significant confusion on awakening. This will suggest the central involvement of pathophysiology and multifactorial nature. The treatment can be behavior modification, alarm therapy, or pharmacological therapy. It is start when there is concern and motivation on the on the part of the child rather than the parents. And active treatment should not be started before 6 years of age. In behavioral therapy, we promote good bowel and bladder habits and we provide reassurance. In alarm therapy, this is based on classic Pavlovian conditional techniques, and other mechanisms are suppression of bladder emptying during sleep and increased nocturnal bladder volume. It is the most effective therapy in the treatment of MSC, and the response is more gradual and sustained, with up to two-thirds becoming dry during active treatment and one half remaining dry after treatment. And irrespective of age, the success is seen in 76% of the children. This is the alarm therapy. The sensor is attached to the undergarments, which is attached to a cord, and this can be connected to an alarm unit or a vibrator. The child is in charge of the alarm, although initially parents may need to awaken the child, and the diary is maintained for wet and dry nights. Positive reinforcement should be given to the child for dry nights and for successful completion of the steps. Approximately 30% discontinues due to skin irritation, disturbance of family members, and the therapy should be continued till there are 14 consecutive dry nights. And if there is no improvement in 6 weeks, the alternative intervention should be used. The therapy can be reinitiated for relapse, and there is rapid secondary response due to preconditioning. Pharmacotherapy, desmopressin, it is a synthetic analog of ADH, available in oral, sublingual, or intranasal form. Half-life is 2 to 3 hours, but it is prolonged in intranasal form. Risk for water intoxication, especially if it is taken with excessive fluids. So intranasal form should be avoided. And the treatment should be interrupted during episodes of excessive fluid intake. The usual dose is 0.2 and it should be titrated by 0.2 to a maximum of 0.6 mg at bedtime. And it is most efficient in children with nocturnal polyuria and normal reservoir function. Relapse rate is 65% versus 46% for the alarm therapy. And it can be given every night or on the special occasions. But if it is used every day, there should be drug holidays to assess the response. Then tricyclic antidepressants, these are the third line treatment, and they decrease the amount of time spent in the REM sleep and stimulate ADH secretion, but they are ineffective once the treatment is stopped. Imipramine is most commonly used. It is available in 10, 25, and 50 mg tablets. We start with 10 to 25 mg 1 hour before bedtime, and it can be increased by 25 mg if there is no response after 1 week. Assessment is done at 1 month, and there should be drug holidays. It is more effective treatment for refractory incontinence. It comes with a black box warning due to increased suicide rates, and it affects the cardiovascular system, so baseline ECG should be obtained. And the common side effects are dizziness, mood changes, GIT, discomfort, and 5% patients have neurological symptoms like nervousness, disordered sleep, personality change. Anticholinergics, these are not the first line treatment because many of the children have reduced functional capacity, and the mechanism of nocturnal detrusor activity makes them an attractive option, and the patient should be reassessed again after 1 month. Then combination therapy may be used, and there are some alternative therapies like hypnosis, psychotherapy, and acupuncture. And this is the algorithm for the management. It can be non-monosymptomatic or monosymptomatic. If non-monosymptomatic, we treat the bowel and bladder dysfunction first. And if monosymptomatic, we first go for behavioral therapy. If the family is motivated, there is no polyuria and low bladder capacity, we go for alarm therapy. If there is nocturnal polyuria, normal capacity, and infrequent episodes, we go for desmopressin. If there is failure, we can switch the treatment and add anticholinergic. If nothing works, we can go for TCAs alone, or we can use for the combination therapy.
Thank you, Abhishek. That was a quite a elaborate description of lower urinary tract dysfunction, but come. So I think one of the most important things we must understand, the main objective or the aim is the topic was functional disorders of lower urinary tract, right, in children. It's not lower urinary tract dysfunction in children. So you must understand that the main objective of today's presentation and was how do you actually diagnose cases of functional lower urinary tract disorders in children, and how you differentiate it from the organic or the neurological causes of lower urinary tract dysfunction in children. So you don't mix them, right? Because the main objective is how do you diagnose the functional disorders? Because we know that almost 20%, 20 to 30% of children and adolescents do suffer from functional lower urinary tract dysfunction. They do not have any organic cause, right? And it is important because many of these patients will have chronic lower urinary tract dysfunction, which will result in many problems, right? And these problems include not only they are socially not acceptable, they have problems with the quality of life. Uh, they do suffer from psychological issues like anxiety, depression, and other problems. But also, this can result in urinary tract infection, recurrent urinary tract infection, even vesico-uterine reflux, and ultimately they may have renal impairment also, not because of any organic cause, but because of this functional problem. And so that is why it is very important, because many of these patients may even have CKD, because if they are not being treated or detected early. So that is why it is very important when we see patients in our OPD, the pediatric patients, we need to identify these patients who have functional disorders early, diagnose them and treat them early, because they may actually land up in chronic kidney disease and many other issues, right? So, as I said, again, in any problem, we have to be very careful about how to take a proper history in these patients. We have to take proper history, particularly when we talk about functional disorders. We have to take the proper history of the toilet training, the habitual sphincteric contraction in these patients, any chronic stress in the family, uh, and any kind of psychological issues, or patients who have hyperactivity disorders, right? All these children, they do have a tendency to develop this functional disorder. So again, very important, you take all this history, and definitely you take other proper history to rule out other neurological causes and organic problem. And then in the family history, there is a condition called familial kind of toilet training problem. Right? Some families have this, they run in the families of toilet training disorders. Right? So that is again important. And then when you talk about nocturnal enuresis, PNE, then again, this can also run in families. And then you also need to take an antenatal history and the perinatal history. Sometimes if there is a perinatal issue, or the child has been born with some kind of anoxia and all that, they can result in functional disorders later. So again, a perinatal history is again very important in these patients. And then definitely there are various surveys and questionnaires which are very useful in taking the symptomatology of these patients. And then voiding diary, definitely. Voiding diary is the key in the diagnostic algorithm of lower functional disorder in lower unit tract dysfunction in children. And then definitely we need to at least do a urine routine examination and urine culture, sometimes if you suspect urinary tract infection. And then if you suspect, then you may do an imaging study like an ultrasound, which is important to rule out residual urine, the bladder capacity, and everything. And very kind of not necessarily in every case, but some patients, specific patients may require other further imaging studies like MRI to rule out the neurological causes. So the things that you showed as a spina bifida occulta, the tuft of hair and all that, they are actually neurological causes, which you will not be there in patients with functional disorder, right? So then again, the urodynamics study is again important, not only to rule out neurological causes, etc., but also in functional disorders, you would like to know what is the exact problem. Because these patients may have detrusor hyperactivity, they may have kind of a hypoactive bladder, they may have residual urine. And all this is because the patient had not been properly trained, toilet training has not been given, and they have some habitual problem, which they are not in a habit of, they do not know exactly how to pee because sometimes they would not be relaxed completely. And so that is why in treatment, it is very important to teach them how to relax your pelvic floor muscles and etc. while peeing, because the picture that you showed was very important. They have to relax their feet and thigh while peeing. So that is why the thigh must be relaxed and the feet. So usually the children have the feet will be hanging, right? So that is why they require a small stool where they can put the feet on the stool so they can get themselves completely relaxed while voiding. So again, urotherapy, as you said, is very important while treating these patients of functional bladder disorders. So urotherapy will include educating this patient, counseling, reassuring, then behavioral therapy, how to give toilet training, how to relax your pelvic floor muscles, etc., etc. So, and then the fluid regimen and the diet regimen. Diet is important in this sense because most of these patients will have some kind of a bowel dysfunction. So, bladder and bowel are very commonly interrelated. It's very important to take a proper history of bowel habit. And many of these patients who have constipation or altered bowel habits will have a urinary tract problem. So treating the bowel is very important in patients of functional lower urinary tract dysfunction in children. And then treatment, as you said, I think you have dealt almost the whole thing. Only thing is that we need to differentiate. The main objective should be how to differentiate between the organic causes and the functional causes. Organic could be neurological causes. It could be posterior third valve, the primary vesicular reflux, the phimosis, meatal stenosis, all these causes which can lead to low unit tract dysfunction. So they need to be differentiated from functional lower urinary tract dysfunction. And I think that is in brief about the whole topic, today's topic. And I would request any faculty or yes, and residents who have any query or anything that you want to ask or make any comment. And those who have joined us, I think Dr. Mallikarjun Reddy, Dr. Amilal Bhatt, and many of them have joined us. I welcome both of you. Nachiket, can we take their comments and then so Dr. Mallikarjun Reddy has already unmuted. So please, Dr. Reddy, you can go ahead. Yes, and welcome once again to our teaching class of Department of Urology, SMS. Thank you for joining us. Please go ahead.
Yeah, thank you. Good morning. Good morning. So it was a nice presentation from Abhishek, actually. There are a few other small points which I think we should be doing in evaluation of these children. We should be doing an MCU in these children. So what the MCU would tell us is, it would tell us whether the sphincter is, the external sphincter is spastic, or are they contracting the external sphincter while voiding, which is a very common phenomenon in these kind of children. That's number one. Number two is that in severe constipations, we can actually do either a MACE or transanal irrigation. Now, transanal irrigation is now the one which is being done, and it is not a difficult thing. We need to use a 20 or a 22 two-way Foley catheter, insert it as much as possible till the rectum, inflate the balloon, and then instill about 100 to 200 or 300, depends on how much that colon can take. The reason to instill the balloon is the water should go up till the sigmoid flexure so that the whole colon gets emptied. So this takes about 40-45 minutes. But if that is not possible, then we may have to do a MACE so that they irrigate antegrately through the appendix. So treatment of constipation takes the primary role in the functional disorders of the lower urinary tract in children. Now, developmentally, if we look at that, the neonatal bladders are actually high pressure bladders. But why do not they affect the kidneys is because they do not have the ability to hold urine. So the ability to hold urine is the most last one to occur. So if we train them much earlier, then the high pressure bladders can cause infection. So that is why the reason is told that you need to hold till about 3 to 4 years for toilet training, so that when the voluntary inhibition of voiding comes in, then the bladder pressures are still optimal. The third thing is the world is coming all around. The West have now, the Boston guys have actually now published data saying that people who squat and void or who squat and pass stool, they have very minimal bladder wall dysfunction for the simple reason that once you squat, the pelvic floor automatically relaxes. Now in India, we were squatting and now we became westernized. And the Westerners are becoming Indians. So the other rationale they have given is the rectal angle would be straight once you squat. So what I do in my practice is I always encourage these children to squat and void. And even if it is a male, our older males used to squat and pass urine. So this would definitely help them. And even for defecation, we always advise that you use an Indian type of toilet so that these children would relax their pelvic floors and then they get out of this. But when we have to use the polyethylene glycol or any of these things, we need to at least give it for 6 months, not less than that, because initially it may feel that everything is going well, but then the colon has to come back to adapt to its normal size. So it will take at least around 6 months, even if they are defecating well. So that's a time, at least a minimal timeline for them to be given laxatives. So these few things I would like to say, Dr. Shivam. And thanks for the invitation also.
Thank you. Thank you, Dr. Mallikarjun. You took time from your OT, we can see. Thank you very much. I think you make very, very important points. That one is about the bowel function, which is usually associated, bowel problem, which is associated, and how to deal with the chronic constipation, severe chronic constipation. I remember there were some naturopathy centers where they do colonic wash, right? So colonic wash is really, really very, I think, very kind of a thing which which makes you feel so light after once you have that colonic wash. And that's what you said about the transanal irrigation, which is very important in these patients. And if necessary, you can do a MACE. MACE, is you make a
Manon antegrade continent enema, just take the appendix and put.
Yes, that's right. So that is again very important for chronic constipation. And then the other important thing that you made was how the squatting position can help children to relax more their pelvic floor muscles and be in a more comfortable manner rather than in what we do on the Western commerce. I think thanks. So we have Dr. Bhatt also with us. Dr. Bhatt, would you like to make any comment? And then we will take Dr. Nachiket's few comments. Yes. Dr. Nachiket, you can come. Dr. Bhatt, yes, go ahead.
Yes, I think most of the points have been taken care, but I would like to add few of the points. Number one is that it is very important to see the stress of the child is very important. Especially many a time, child doesn't tell about the school stress to the parents. So that has to be evaluated and seen. Go and talk to the teacher how he behaves in the school. Second thing is that the in females, even the females, organic causes has to be ruled out. Among the organic causes in the female child is one is that even female child have recurrent urinary tract infection that has to be ruled out. Another is a vaginal voider. Vaginal voider is a very important one, and especially if they are vaginal voider, they should be evaluated for female hypospadias. And vaginal voiding is again a reason for the uh, detrusor sphincter dyssynergia, because the moment water goes in vagina, there is a spasm of the external sphincter, and repeated that leads to the detrusor sphincter dyssynergia. These are two important points. And uh, this one, nocturnal enuresis. You see, you have to spend some time with the children to get the right history, as well as the important point is that to spend time, because in most of the time we the VG clinician don't spend time with the child, and to have good narration you have to be um, friendly with the child, spend some time, and child tells about all these things. And for behavioral therapy also, if you make them understand, they do well. So with these few points, I think most of the points have been covered, and I must compliment and congratulate for such a nice the CME you had. Thank you very much.
Thank you, Dr. Bhatt. Thanks. You made those very important points that how psychological problems or stress in children, and particularly the school-going children who are in habit of holding their urine, right? Sometimes the their teachers would not allow them to go out of the classes to void, or they are hesitant in going out and asking the teacher for void. So these are very important issues because they get into the habit of holding their urine, and sphincteric contraction, habitual sphincteric contraction, that results in this functional disorder. And the second point you made about the vaginal voiding. Yes, many females do have the children, female have labial adhesions, right? So if they have labial adhesions, usually the urine will get collected into the vagina and then it will come out, spill out of the vagina. So pseudo incontinence, which is called. So again, yes, that is very important to rule out all these problems in children also. So thank you both of you. So I would request Nachiket to make some comment.
I just wanted to make one point.
Yeah.
And, Sir, I was listening to one of the lectures by Dr. Rama Jayanti, and a very important thing that he stressed was even forceful voiding by parents and peers. For example, the child does not want to go to void. And every time, for example, if they have to go to the marketplace or they have to go to, the parents are forcing the children go to the bathroom and he's saying, I don't want to go. Then they reach the, say, market. And as soon as they see a toilet, they don't want to, the inconvenience of say finding a bathroom later on, they will force the children to again and again to go to the toilet. Then what happens is that the bladder is still inside a phase of becoming an adult bladder from a child bladder. So that's why that also they was discussing as a possible cause of dysfunction, which they called as the forceful voiding syndrome. So that should also be, I mean, looked into that. Have you trained your bladder in such a way that the pelvic muscles are getting exercised for no reason at all? Like, so I just wanted to tell about that, which maybe can be looked into as one of the possible causes of non-urogenerating bladder. Then I wanted to ask Abhishek, when he was telling about MSc, then you were saying that other treatments also they are given. And then surprisingly, one of the treatments that you said was furosemide. And immediately I told sir that how can furosemide be useful in MSc? So maybe you can shed some light on that.
Yeah. Would you like to say anything? I think he wanted to say because particularly patients who have nocturia, monosymptomatic nocturnal enuresis and nocturia or nocturnal polyuria, uh, that is usually the treatment in patients, adult patients who if you give a diuretic in the evening so that they can completely void before they go to bed, so that the nocturnal volume is reduced, so that the chance of having nocturia or enuresis gets probably. So, would you like to make any other comment? Right. Okay. Right. So I think that is all. So Dr. Reddy, would you like to say anything? We
No,
will
no,
go
I was just trying to look at the furosemide scenarios in nocturnal enuresis in children. At this point, actually, there is no role. You are absolutely right that it is for nocturnal polyuria in adults. So here, yeah, the only issue with the alarm therapy is the criticism is you will know only after there is enuresis or there is wetting. So you don't know things before, but still it remains the primary treatment of nocturnal enuresis along with desmopressin. The timelines are the big issues here, that everything is in months, nothing less than 6 months. But the voiding diaries are the most important thing, as you said, that without a voiding diary, we should not be doing anything. That's the only thing which I would like to say. Thank you, Dr. Shivan.
Thank you. Thank you. I think the important point is here is that it's usually for adults, not in children. And secondly, nocturnal enuresis treatment, alarm therapy is again probably is primary therapy. And though desmopressin is the treatment of choice as a pharmacotherapy, we have been giving imipramine to many of the patients who cannot afford desmopressin, or and even otherwise also. And the criticism of desmopressin that it has some neurological issues and suicidal tendencies and all that, at least we have not found, right? So we have been giving so many patients, children, imipramine. We have never found these kind of severe side effects. All right. Any take on that, Dr. Reddy, about imipramine in children?
No, we still don't know, because I don't understand whether we do those investigations or we don't do the investigations. But in our clinical practice, we see that it is extremely safe. But then they say that it prolongs the QT interval and then has got cardiac issues. So that's why it has gone into a little disrepute. But you and I know that we would have used tons of imipramine for our children. So I think we need to take those data with a little pinch of salt, or probably we also need to get our own data that every time a child on imipramine comes back, I think we should do one small ECG and just document how many of our children really would have it. I do an ECG, but I haven't really found an issue with most of the children. So we don't know. So there's a lot of things within our population which doesn't sync to the other population too.
Dr. Nachiket was saying that there may be some drowsiness in school-going children who take imipramine.
Fair enough. You can actually withdraw that in case there is an issue.
Yeah, that's right. Thank you. Thank you.
Thank you, sir. Thank you.
Thank you. I will go to the MCQs now.
Yeah, thank you very much. I'll take a leave from you, sir. Thank you.
Sir, please vote for Shivam.
No. Okay. Okay. Thank you. Thank you, Dr. Reddy and Dr. Bhatt. We will go for the MCQs. Please go ahead. So, yes, okay. So the EMG lag time, or what is the question here? Go for it. EMG lag time greater than 6 seconds typically corresponds to what potential patient presentation? Normal voider and bell-shaped uroflow curve, overactive bladder and lower uroflow curve, primary bladder neck dysfunction and plateau uroflow curve, underactive bladder and staccato uroflow curve, and controlled incontinence. C, primary bladder neck dysfunction. EMG lag time greater than 6 seconds. Okay. So do you agree? Okay. So primary bladder neck dysfunction and plateau uroflow curve, EMG lag times of 2 to 6 seconds are considered normal. and times less than 2 seconds are seen with bladder hyperactivity, and times greater than 6 seconds indicate primary bladder neck dysfunction associated with the Euroflow curve that plateaus or flattens after the initial rise. Right. Second, which are valid methods to define functional bladder capacity? Voided volume on Euroflow plus PVR, H plus 2 into 30, smallest voided volume on voiding diary, largest voided volume on voiding diary, A plus D. A plus D? So A plus D is voided volume on Euroflow plus PVR and largest voided volume on voiding diary. That is okay. Functional bladder capacity is a measure of day-to-day capacity of a patient's bladder. This number should reflect how much of a particular patient's bladder holds when full. This is reflected by voided volume on Euroflow plus PVR and the smallest voided volume on voiding diary. Corresponds to the patient's estimated bladder capacity. Doesn't reflect any clinically useful measure of the bladder, right? So what is the significance of debris visualized within the bladder of collecting system on ultrasound? So increased risk of UTI? Is it? Increased risk of positive urine culture regardless of symptoms. Okay. So yes. So regardless of the symptoms, the patient may be symptomatic or not, but the urine may be turbid or infected if there is ecogenic debris. I think that's very simple. What test is recommended for all patients who present with lower urinary tract symptoms and no prior urologic diagnosis? Urine analysis, urodynamics, serum creatinine, Euroflow, renal bladder ultrasound. So if one test has to be chosen, that is urine analysis. To rule out the presence of a urinary tract infection. Yes, many patients of functional disorder can have recurrent urinary tract infection because of the urinary stasis. They are not able to hold, they are able to holding it for a longer time, and there is some stasis that results in urinary tract infection. Which cutaneous finding over the sacral spine on exam is at the highest risk for diagnosis of occult spinal dysraphism? Right. So, yes, symmetric by hypertrichosis. Hypertrichosis is a generalized, right? Cutaneous dimple. That is right. Hemangioma? Acha. Highest risk of is hemangioma. Hemangioma over the back, the same region. Okay. So the risk of occult spinal dysraphism is different for each of the listed regions. From the lowest risk to highest, they are simple cutaneous dimple, asymmetric bifid gluteal cleft, hypertrichosis or hair tuft rather, and dermal sinus tract and hemangioma. Okay. What test treatment is recommended in patients with lower urinary tract dysfunction who failed first-line conservative therapies? That is called urotherapy, right? Behavioral modification, time voiding, avoidance of bladder irritants, etc. A 7-day bowel and bladder diary, formal video urodynamics, treatment with antimuscarinics, treatment with alpha blocker, intradetrusor injection of botulinum toxin. So whether you want test or treatment, there's two different. So if you want to say treatment, then probably it requires pharmacotherapy. All right. So if you want to say test, then so test is urodynamics or for diary. Diary, if you haven't done with the diary, usually the diary has to be before the behavioral therapy, right? Right. So diary is a part of the whole your evaluation before you start the treatment, right? So in that case, probably the urodynamics is the second investigation. Otherwise, definitely diary is important. What finding may be reduced on urodynamics when performed under sedation? Detrusor overactivity, compliance, detrusor leak point pressure, bladder capacity, internal sphincter control. Overactivity? So yes, so many of these children, because they would not be tolerate urodynamic study, putting the catheter in the without sedation. Many may require sedation, so here the detrusor overactivity may be reduced, right? Demonstrate the only parameter reliably affected by sedation or anesthesia is detrusor overactivity. If it were present normally, it would not be present on a sedated urodynamic study. Compliance, DLPP, and bladder capacity are generally not affected. The purported mechanism of action for botulinum toxin in the treatment of children and adolescents with dysfunctional voiding is reducing the frequency and intensity of uninhibited detrusor contraction, smooth muscle relaxation at the bladder neck, paralysis of the striated muscle, stabilization of motor end plate, inhibiting spinal cord feedback loops, none of the above. Right? Which one? D, you mean to say? C. Okay. Paralysis of striated muscle of external sphincter? No. If you are giving an intradetrusor, no, that is totally different. But giving injection in botulinum toxin in external sphincter is different from giving it in detrusor. For in detrusor, it is given for detrusor overactivity. And for external sphincter, it is given for dysynergy. Well, external sphincter dysynergy. So there are two different treatments. Right. So, paralysis of the striated muscle of the external sphincter. Botulinum A toxin acts by inhibiting acetylcholine release at the presynaptic neuromuscular junction. Inhibited ACH release results in regionally decreased muscle contractility and atrophy at the injection site, which in the case of dysfunctional voiding would be the striated muscle of the external urinary sphincter. The chemical denervation that ensues is a reversible process, and eventually the toxin is inactivated and removed. So many of these patients, because they have a habit of sphincter contraction, right? So these patients may be helped because of the sphincteric spasm, can be helped by injecting botulinum into the sphincter. An 8-year-old boy presents to your office with his parents for consultation regarding treatment for primary nocturnal enuresis. Behavioral modification, desmopressin, and the enuresis alarm have failed, right? Which of the following parameters is the best predictor of response to treatment with desmopressin? The age of the child, the bladder capacity, the motivation of the family, nocturnal polyuria, poor errors. Huh? Bladder capacity? Nocturnal polyuria? Nocturnal polyuria is the best. Right. So the nocturnal enuresis alarm and desmopressin are both valid treatment options. There exist patient, caregiver, and disease-related parameters that may aid in offering prognostic information in terms of which therapeutic modality should be first entertained. The enuresis alarm seems best fit for motivated patients and families and for children without polyuria, but with low voided volume. Desmopressin seems best suited for children with nocturnal polyuria and normal bladder reservoir function for those with infrequent wet episodes, and for families in whom alarm treatment is failed or who have refused alarm treatment. Thank you. So that was all. Thank you, everybody. If you have any query, any of the residents? Okay. So I thank all my faculty, residents, all my experts, particularly Dr. Mallikarjun Reddy and Dr. Amilal Bhatt for joining us.